It's again my pleasure to introduce Professor Christopher, and he this time will address the importance of maintenance versus no maintenance in colorectal cancer. Okay.
So as you've heard earlier, with the panoply of new agents, our overall survival has gone from 6 to 9 months with 5-FU alone to over 30 months. And our problem now is becoming less controlling cancer symptoms, but now a big struggle is controlling the cumulative toxicity of this chemotherapy and kind of threading the needle between controlling symptoms as well as managing side effects of therapy. So as you know, the main cumulative side effect of oxaliplatin is neuropathy, and almost everyone who gets above 800 milligrams per meter squared will get grade 3 neuropathy. The other thing we're seeing increasingly with the chronicity of therapy is we're seeing patients develop portal hypertension, varices, splenomegaly, and cytopenias due to drug-induced liver injury. So they're looking at where patients are often wanting to be very aggressive and very happy with responses. Sometimes we're having to tell patients early in the course we have to kind of dial back on the treatment for the long course, try to preserve organ function, and reduce long-term cumulative effects. So there's a number of different strategies were introduced, particularly these started off with addressing oxaliplatin neuropathy. And the different strategies were, one was a complete treatment break. And this is sometimes popularly known as a drug holiday. This is very popular in the United Kingdom. There's also a situation where they can have reduced intensity of chemotherapy, so no cytotoxic therapy, but only biologic therapy. And Professor Schmoll mentioned the DREAM study, and I'll go into that now, as well as the Cairo 3. And the other option is low-intensity cytotoxic therapy, such as 5-FU combined with biologic therapy. So when you devise these protocols, you also have to determine when the stop should occur. Should it occur at time of best response? Should it occur after a fixed number of cycles? And even in some of the studies, when do you reintroduce treatment? Do you wait till progression occurs, or do you reintroduce therapy at a fixed time point? So this is the two studies, Optimox 1 and Optimox 2. They were small randomized phase 2s. They weren't really designed as non-inferiority trials. But you can see here Optimox 1 looked at continuous FOLFOX progression. And the alternate was 3 months of FOLFOX versus 3 months of infusional 5-FU. And just to remind you, the LV5-FU2 involved the 46-hour infusion of 5-FU as well as bolus 5-FU leucovorin. And I must say, in our routine practice, we've now pretty much dropped bolus 5-FU leucovorin from this treatment regimen. We feel it adds toxicity but not efficacy. So overall, again, this was not a non-inferiority trial, but they did not see a significant difference in progression-free or overall survival, suggesting that you could do intermittent oxaliplatin therapy. And I didn't show the data here, but there was significantly less neuropathy in the Optimox 1 group, as you'd imagine. So they then went on to compare this to an Optimox 2 approach, which is a complete drug holiday, which would be very similar to what they do in the United Kingdom, a 3-month. Now, the one thing about this approach, Optimox 2, a strange twist in the study design, is they reintroduced chemotherapy when the patients had progressed beyond their baseline. So if patients had a major response and then were progressing, they would maintain them on a chemotherapy holiday until they developed progression beyond their baseline. This would not be sort of a routine clinical practice, so that makes it hard to interpret these results. But you can see here that the complete drug holiday, which they call Optimox 2, was inferior in terms of disease control and progression-free survival, a trend towards worsening progression-free survival. So based on this data, drug-free holidays would not be recommended universally. So what about biologic therapy, using that as a backbone? This is a trial, the concept trial, and they were comparing patients who got intermittent FOLFOX therapy versus FOLFOX plus bevacizumab therapy. This particular trial, as you know, it also looked at the introduction of calcium and magnesium, and was stopped early due to differences in response rate by a data monitoring committee. But the other trial, which I think is very interesting, was the DREAM trial. It looked at dual biologic. It looked at EGFR receptor tyrosine kinase inhibitor plus bevacizumab as the maintenance therapy compared to bevacizumab alone. And I was a little bit cynical initially. I said these two biologic therapies were made by the same company, and that's one of the rationale. But I think there is some important data now that there's crosstalk between stromal cells and tumor cells, and there's fairly extensive preclinical background that EGFR receptors on tumor-associated endothelial cells can change the environment and affect tumor growth. I think Dr. Schmoll showed this data that overall there was some synergy with bevacizumab and erlotinib in xenografts. Now, the study was very interesting. The results did show a progression-free, a trend towards progression-free survival. And at the time I had this data, there wasn't an overall survival benefit, but there was a trend towards an overall survival benefit. And tolerance of the erlotinib arm was acceptable. And for this study, they did not have data regarding KRAS mutation subtypes. So it would be very interesting to look to see if KRAS wild type would have a significant survival benefit using the biologic couplet in the second line. So I think this is still an area of interest, of development. Right now it's not standard of care, but I think it's an area that may bear some fruit. So this is the macro trial, the Spanish macro trial, and it's looking at bevacizumab monotherapy as maintenance therapy compared to chemotherapy plus bevacizumab continuously. And similarly, as I mentioned before, it was a small randomized phase 2. It was not powered to be a non-inferiority trial, but you can see here that there was not a statistically significant difference in progression-free survival or overall survival when bevacizumab was used as a monotherapy as maintenance. So I think this trial would support the use of bevacizumab monotherapy as a maintenance strategy. This is data just looking at response rate. As you know, response rate is very controversial in colon cancer and how significant, if at all, it is. But you can see there's not a significant difference, although a trend towards a higher response rate in the bevacizumab monotherapy arm group. And the second and third line and fourth line therapies were approximately the same. So as I mentioned earlier, in the United Kingdom, they tend to do more drug-free holidays, and two of the arms of the COIN trial looked at this. As you know, it was primarily looking at the effect of cetuximab in the frontline setting. But arm A was looking at CAPOX or FOLFOX continuously to progression, and arm C was looking at intermittently and retreatment at time of progression. There's no biologics involved in this arm A and C comparison. But overall, there was an intention to treat analysis. There was no difference in overall survival between the two arms. So this would be an argument, not using biologic therapy, this would be an argument for drug-free holidays. So there's one final study that just came out, the Cairo 3 trial, that looked at maintenance capecitabine plus bevacizumab therapy. There's an interesting point here. They looked at continuous daily capecitabine therapy, which is interesting. Certainly makes it easier for patients who are on Coumadin therapy to be on a fixed dose, daily dose of capecitabine. And there may be some metronomic effect to continuous dosing. Patients who had a response were randomized to this low-intensity chemotherapy plus biologic arm versus observation. And you can see here that there was statistically significant progression-free survival benefit. They described two, PFS 1 and 2. PFS 1 was from the beginning of therapy until their second progression. PFS 1 was from the beginning of therapy to the time of progression on biologic. But there was a PFS benefit in both instances, but not an overall survival benefit. And we already talked earlier where it's difficult in a frontline study to show survival benefit now, given the plethora of subsequent treatment options available. So in summary, what is the best approach? I think you have to individualize approaches for patients, and certainly which patients can benefit from a drug-free holiday. I think in our practice, patients with peritoneal disease, we're loath to take those off chemotherapy because the chance of them becoming symptomatic is very high. Alternatively, people with lung-only disease, they tend to be very indolent. Lung metastases tend not to give symptoms in contradistinction to osteogenic sarcoma or renal cell to the lung. So patients can be observed with rather indolent progression. So I think you have to individualize based on tumor burden and anatomic location of the metastatic disease. And obviously, you have to take patient preference into consideration. In selected patients with low-volume disease, I think it's reasonable to do chemotherapy-free holidays. In patients with high-volume disease, our practice is to use 5-FU bevacizumab as maintenance until progression, and then reintroduce oxaliplatin. That's just my practice. I think the macro trial could argue you could use bevacizumab monotherapy alone. Thank you very much.
Thank you very much, Professor Christopher. So we have just 6 minutes for any discussion or question, and then we go to the next speaker.
I just have a comment about, there was about a couple of weeks a meta-analysis of the randomized trial that did look at the complete chemotherapy stop in metastatic colorectal cancer, and it did not show any difference in terms of the outcome in those patients who did stop the chemotherapy and those who continued.
Would you like to comment? Let's go with his recommendation and his...
Yeah, thank you for your very nice talk, and I fully agree with you. And I think in those patients who will receive multiple lines of chemotherapy, it is hard to believe that they can receive it for 30 months, even with maintenance. I mean, maintenance, as you have shown, is increasing progression-free survival, but in most of the cases, there is no increase in overall survival. And the stop and go is certainly a way to go, if I could say. And moreover, the patient decision is very important to take under consideration, because, you know, even if maintenance is lighter, they still have to come to receive their BEV injection and take their pills of capecitabine. If they have a full stop and go, they go away for 2 months, they forget about it. And it's better in terms of quality of life. I think, even though I'm not a strong believer in quality of life because of the tools we have are not really appropriate. My quality of life is not your quality of life. There are other tools to be used, like the Q-twist analysis, a time without symptom or toxicity, things like that. We are more refined. Unfortunately, they are rarely used, but it is very important for this patient who will live for 2 years and a half or so to think about quality of life, because we will not cure them anyway.
Yeah, no, I agree completely. I should have mentioned, I often do a thought experiment. I say, if this person doesn't get therapy for 3 months and gets 20% progression, how much trouble are they going to get into? And if it's not too much, you know, then I think it's a risk worth taking. And I agree very much about patient preference. You know, some people have a cruise they want to go on. Some people want to come in every 2 weeks to get bevacizumab. They feel insecure going home. They feel abandoned if you tell them, go away for 3 months and I'll see you later. So, you know, I think the patient's comfort level, there may be some benefit to the doctor-patient relationship in that situation.
So it's my pleasure to introduce Dr. Jean Delard again, and the title of his